Okay, so yesterday we saw in short lasers commonly used in photocoagulation, and today we're gonna read influence of opacities in the ocular media upon laser parameter power. Any opacity in the ocular media such as corneal edema, corneal haziness, flare, and cells in the anterior chamber, lentil opacity, and Vitreous opacity reduces energy level of the laser beam striking the retinal surface by reflection, scattering, or absorption of the laser beam. Hence, the optimum power level should be arrived at by gradually increasing the power to cause optimum coagulation burn for the procedure. Gradation of photocoagulation lesions. Visible photocoagulation intensity of chorioretinal tissues except retinal vessels can be graded from grade 1 light to grade 4 heavy. Table 1.1, figures 1.2 and 1.3. Similarly, visible photocoagulation of retinal vessels can be graded from grade 1 to grade 4, figure 1.4. The grading is clinically very significant to ascertain the end point or optimum intensity of photocoagulation indicated for a specific retinal lesion. For example, grade 1 light chorioretinal coagulation is optimum intensity of photocoagulation in focal or grade laser in diabetic maculopathy, whereas grade 3 or moderate chorioretinal coagulation is optimum intensity of photocoagulation in scatter or panretinal photocoagulation (PRP), retinal breaks and abnormal blood vessels. So gradation of photocoagulation lesions in table 1.1, various chorioretinal coagulations, grades 1 that is light to grade 4 that is heavy. So grade 1 that is light, grade 2 is mild, grade 3 is moderate, grade 4 is heavy. So I think I'm not at the center. Yeah. Grade 1 or light, barely visible blanching of retinal pigment epithelium. Grade 1 or light is barely visible blanching of retinal pigment epithelium. Grade 2 mild is hazy faint white retinal coagulation. Hazy faint white retinal coagulation. Grade 3 is moderate. Opaque dirty white retinal coagulation. Grade 3 moderate is opaque dirty white retinal coagulation. Grade 4 is heavy dense white chalky retinal coagulation. So grade 1 is light, grade 2 is mild, then grade 3 is moderate, grade 4 is heavy. So mild, moderate, there is no severe, mild, moderate and heavy. And first is light, mild, moderate and heavy, grade 1, 2, 3, 4. And first is barely visible blanching of retinal pigment epithelial cells. Then grade 2 mild is hazy, faint white retinal coagulation, Then grade 3 moderate is opaque dirty white. First is faint white coagulation, then opaque dirty white is grade 3, and grade 4 is dense chalky white retinal coagulation. Now gradation of photocoagulation lesions. Visible photocoagulation intensity of chorioretinal tissues except retinal vessels can be graded from grade 1 or light to grade 4 heavy. Table 1.1, I have already read it, so this thing I'll read. Focusing of laser beam. All the lasers except xenon arc emit monochromatic rays. All the lasers except xenon arc emit monochromatic rays. So xenon arc emits multiple wavelength laser. So energy of these lasers except xenon arc can be focused to a fine point without significant chromatic aberration. Figure 1.2, schematic drawing of various chorioretinal coagulation, grade 1 to light to heavy. Then schematic drawing of various vascular coagulations, grades 1 to 4. One is minimum visible constriction of the vessel. Second is total constriction, grade 2, total constriction and spasm of the vessel. 3 is total constriction of the vessel along with the coagulation of the surrounding tissue. And grade 4 is total constriction, charring of the vessel, coagulation of the surrounding tissue. So grade 1 is minimum visible constriction of the vessel. Grade 1, minimal visible constriction of the vessel. Then grade 2 is total constriction of the vessel and spasm of the vessel. Spasm of the vessel and total constriction of the vessel, that is grade 2. Grade 3 is total constriction of the vessel along with coagulation of the surrounding tissues. And grade 4 is total constriction, charring of the vessel, coagulation of the surrounding tissue. So total constriction is grade 2 to 4 and grade 1 minimal visible constriction of the vessel. Grade 2, 3, 4 total constriction. Grade 2 total constriction and spasm of the vessel. Grade 3 is total constriction along with the coagulation of the surrounding tissue. Grade 4 is total constriction along with the coagulation of the surrounding tissue plus charring of the vessel. So there is a figure here. I'm not gonna edit the video. You can just download this book. I just got it downloaded from the Telegram channel, Ophthalmology book channel. There was some Ophthalmology book channel, I forgot. From there I downloaded this book. The properly focused laser beam in an eye without any opacity in the refracting mediums should be circular with clear-cut margin. An oval beam with a blurred outline indicates incorrect focusing. A, B, C, D, E, F. A is properly focused laser beam without any opacity in the refracting medium. First I'll read and then we'll see the figures. However, opacities in the ocular refracting mediums will not only block a certain percentage of laser beam energy to reach retina but also superimpose a shadow on the round laser focus. The round focused beam may take the shape of following distorted images: small or large wedge-shaped deficit cortical cataracts, elongated and irregular outline astigmatism, large irregular deficit vitreous opacity, round hazy focus and irregular outline, diffuse haziness of ocular media. So the circular target beam should be critically examined before proceeding to laser procedure. So how the laser beam should be? It should be round with clear-cut margins, a clearly focused laser beam. But whenever there are opacities in the ocular media, the focus has different forms. So in cortical cataracts, it is small or large wedge-shaped deficit. Small or large wedge-shaped deficit is there. Then elongated and irregular outline astigmatism. Astigmatism, it is elongated focus and irregular outline. And then vitreous opacity, it is large irregular deficit. Large irregular deficit in vitreous opacity. Then diffuse haziness of ocular media, round hazy focus and irregular outline. It is round but irregular outline. So figure 1.4, focusing of laser beam. A, properly focused laser beam without any opacity in the refracting medium. How it is? It is round and well-defined margins, clear margins. B, oval beam with blurred outline, incorrect focusing. Then C is large wedge-shaped deficit, cortical cataract. In cortical cataract, there is large wedge-shaped deficit. Then D, elongated and irregular outline astigmatism. In astigmatism, it is elongated with irregular outline. E, large irregular deficit, vitreous opacity. In vitreous opacity, there is large irregular deficit. Means some portion is missing and it has irregular margin. Then F, diffuse haziness of ocular media, round hazy focus and irregular outline. So that was about the laser focus beam. Then ND-arc laser 1064 nanometer emission rays are invisible since 1064 nanometer is at infrared end of the light spectrum. Single or multiple helium neon HENE 632.8 8 nanometer visible red beams are usually employed for aiming of Nd:YAG laser 1064 nanometer, diode red 670 nanometer may also be employed as aiming beam in Nd:YAG lasers 1064 nanometer. Laser parameters: power equals to number of photons emitted each second and is expressed in watts. W. Power expressed in watt. W. Exposure time: the duration in second, SEC. The photons are emitted in each burn from the laser. Spot size: the diameter of the focus laser beam and is expressed in micron meter. Spot size is usually fixed for the treatment of a particular lesion. However, the energy, power into exposure time parameters must be decreased or increased. With the decrease or increase in the spot size parameter, the spot size when focused on the retina depends on 1. Laser spot magnification factor, LSMF means the kind of lens used. Laser spot magnification factor, first thing LSMF, laser spot, then of the laser lens. Then it depends upon the type of the lens we are using. Then spot size selected in the slit lamp, spot size, and refraction of the under treatment, eye under treatment, and the refractive error of the eye. Ouch. There is something, I think, some ant or something. Okay. Energy calculation. 1 watt is equal to 1 joule of energy derived in 1 second of exposure. 0.5 second exposure with 2 watt power parameter, 1 joule coagulative energy. 0.5 second exposure with 1 watt power parameter equals to 0.5 joule coagulative energy. Now, post-coagulation advice. The following restrictions are advisable to continue for a period of 3 weeks post-laser. The aim is to reduce or control the venous pressure rise in the eyes, head and neck region. Avoid sneezing, cough and constipation and control with medication. Do not lift heavy objects. Avoid heavy exercise and yoga. Avoid sudden jerky movements of the head. Only paracetamol can be taken orally as a painkiller. During sleep level of head should be above the level of heart. Avoid medications containing ephedrine and epinephrine. It is ideal to supply post-coagulation advice in a printed format. Now, photovaporization, photoablation, photoradiation, I have already read, and photodisruption also, I have already read about it. Laser delivery. Laser can be delivered through 3 types of approach. 1. Slit lamp biomicroscope. 2. Laser indirect ophthalmoscope, LIO. Then intraoperative laser endoscope. Laser delivery. Laser can be delivered through 3 types of approach. First, slit lamp biomicroscope. The most common and popular delivery system. Laser parameters, namely power, exposure time and spot size, can be changed. Laser indirect ophthalmoscope, LIO. Argon green and tired lasers are delivered through a fiber optic cable. Ideal for photocoagulation of peripheral retinal breaks and degeneration. Obviously, through indirect ophthalmoscopy, we can see the periphery of the retina. So, ideal for photocoagulation of the peripheral retinal breaks and degenerations. Ideal for panretinal photocoagulation, scatter photocoagulation of extreme retinal periphery, same in eyes with rubeosis iridis, proliferative diabetic retinopathy, PDR, that is, post-CRVO, central retinal venous occlusion, retinopathy of prematurity, ROP, etc. Ideal for photocoagulation in children under general anesthesia. Ideal for photocoagulation in eyes with small pupil, intraocular gas and lentil opacities. My voice. Excuse me for my sore throat. Unsuitable for focal and or grid laser of macula. Spot size is altered by the dielectric strength of the handheld condensing lens and moving a lever on the headset. Spot size is also altered by the refractive status of the eye. The spot size in a hypermetropic eye is smaller than in an emetropic eye, whereas the spot size in a myopic eye is larger than in an emetropic eye. In LIO, that is laser indirect ophthalmoscopy, retinal spot size is equal to power of condensing aspheric lens into image plane spot size divided by 60. Retinal spot size in LIO equals to power of condensing aspheric lens image plane spot size divided by 60. Intraoperative laser endoscope. Argon green end-tired lasers are delivered to laser endoscope during vitrectomy. Ideal for photocoagulation of retinal surface neovascularization (NVE), peripheral retinal breaks and degenerations after retina is attached by internal fluid-air exchange after vitrectomy. Since detached retina cannot be treated prior subretinal fluid (SRF), removal is essential before application of laser. Obviously, when there is a fluid, we cannot just laser it because the rays will be scattered, the power won't be delivered, and we cannot even see properly in the area. So obviously for subretinal fluid should be removed, then detached retina should be visualized properly, and then laser, it should be laser, endolaser. Ideal for photocoagulation of giant retinal tear. What is that? Laser endoscope, obviously for good visibility. Indications for infiltration anesthesia. As usual, uncooperative patients, presence of insignificant ocular movement, for example, nystagmus. Third is presence of significant ocular pain and photocoagulation near the macular center. So I'll stop this video here. I have read two and a half pages. Then Pascal pattern scan laser. I'll just make a separate video because I want to add a small video on pattern scan laser so you can understand it in a better way. What is it? So that's it. Thanks for listening to me patiently. Goodbye. Take care.